How are they treated? Tom?
Thank you, Dr. McKinsey, and thank you for inviting me. Topic of my talk, as mentioned, is gutter leaks and how to treat them and how they can be prevented. No disclosures. The only disclaimer I have is that vis-a-vis what Dr. Sanchez was alluding to, I'm a sort of a proponent of FEVAR rather than CHIMP a priori, and I tend to reserve chimneys for emergent cases, those who are anatomically unsuitable for FEVAR, hostile anatomy, perhaps similar to the one just presented, and then a rescue following a failed EVAR. Having said that, this is a starting case, a case of mine, 85-year-old woman, severe neck angulation, aortoiliac occlusive disease with some symptoms, and you can see here trying to get through the left side was impossible. We went ahead and put in an endurant, and you can see here we're left with a type 1A, and so we then chose to put a chimney in that side. You can see that the standard kissing technique you just saw, and the completion unfortunately did show a small leak. We chose to leave that alone, and that gutter leak resolved at post-op day 30. So that's just by way of introduction. We do know that EVAR with parallel grafts predisposes to gutter leaks. This is sort of an inevitability, and you can see the natural history and potential morbidity of these leaks remains unclear. Treatment and management has not been established regarding this pathology, at least not in a unified way. We all know oversizing is important. We just heard a 15 to 20%. I think that with the more chimneys you use, you tend to want to oversize more. Just basic geometry and math is shown here. Most of us, I think, would opt for maybe 25 to 30% oversizing. The Pericles registry is the largest retrospective review of data looking at chimneys, and you can see in this registry from Europe and the US, 517 patients, 898 chimney grafts. You see excellent primary and secondary patency at 17.1 months. Some of the variables, anatomic, intraoperative variables, and as well as stent grafts, you can draw your attention to the infrarenal neck, which in this series was 4.8 millimeters. Devices were primarily suprarenal fixation, tended to be Endurant in Europe and Zenith in the US. The types of chimney grafts are shown, and about 25% had this endo lining with bare metal stents after primary stenting of the chimney. Interestingly, completion angiogram demonstrated 7.9% type 1A endo leak, and after corrective treatment, this was reduced to 2.9%, so not too bad. But what about sort of more single-center prospectively collected data? And here you can see Jason Lee and his group from Stanford, prospective series of high-risk patients with at least one renal or other chimney, collected primary endpoints shown here and secondary as well. And you can see they had 60 chimneys. 35% now had some sort of type 1A endoleak on completion angiogram. 14 of these persisted, and you can see here there were some new de novo type 1 leaks also captured at 30-day imaging for a total 30% gutter or type 1A endoleak seen at 30 days. Some aneurysm characteristics, there's no correlation between acuity of presentation or the different types of aneurysms with regard to type 1A endoleak. Likewise, radiologic data shown here. You can see that neck diameter and length did not correlate. Calcification, thrombus also not significant. There was, interestingly and ironically perhaps, a sort of unexpected, these are small numbers of course, but there seemed to be the longer the chimney, the longer the gutter, there was actually a slight predisposition or trend towards leak. This is sort of paradoxical, and I'm not sure what to make of that, but draw your attention to that. Some procedural data here correlating oversizing. Most of these were 25% oversizing, neck length, etc. Again, no real statistic correlation, and more data on snorkels, self-expanding versus balloon expandable, etc. When you look at those 18 leaks that were seen at 1 month, they were tried to categorize and predict, or stratify into a low or high flow. Roughly half were low and the other 9 or half were high flow. You can see an example. Their definition of a low flow would be a leak that extends a centimeter or 10 millimeters below the chimney. And this is an example of a high flow, which is extending much more and actually fills the sac. This is clearly of greater concern, sort of intuitively, than the low flow. When you look at the low flow leaks, natural history of these 18, again, 9 were low flow. You can see there was spontaneous resolution in almost all of these. And you see at 1 month, you can see this small low flow leak, and then at 6 months, this leak has disappeared. There was one that did persist but didn't have any sac growth. And how about the high flow? You see these 9 patients resolved in 4. 1 required reintervention and persisted in 5, and 2 of those actually required some sort of intervention for sac growth. So this is the conclusion of this paper anyways, that there does tend to be spontaneous resolution of these gutter leaks at 6 months and 71%, albeit with small numbers. When you try to break down low flow and high flow, no significant difference, but the low flow tended to resolve spontaneously. So which gutter leaks matter? And now we're getting to the crux of this. There's a difference between the high flow and low flow, clearly. There's some recent efforts or attempts to categorize these into, this is Michel Reinen's group and De Vries from the Netherlands, into type A, B, and C. And this is the beginning, almost harkens back to the days of endoleak classifications. So the type A would be a gutter leak that originates at the proximal edge and extends downward. And further classifying, the type 1, A1 goes down into the sac, the A2 is sort of limited to the branch, and the A3 does not extend past that branch. The B would be a leak that sort of originates and is a malapposition between the stent and the chimney graft and the visceral artery. The B2 is limited to the crotch here, the B1 extends into the sac. And the C would be something that's just sort of a focal leak right at the crotch there, originating below the proximal beginning of the fabric without any connection to the sac. So you can see here their proposed algorithm. It's only those type 1A, A1 and 2 that really need some intervention. This is, again, a rough blueprint on how to approach these gutter leaks. Murray Shames and his group, Martin Back from South Florida at the Southern this year, presented this retrospective review of their patients, their series. All leaks were classified, again, low flow or high flow. And you can see here an example of a low flow, very confined to the proximal sac, whereas the high flow is really filling the entire aneurysm sac right here. They had 78 patients with 28 gutter leaks, 35.9% here, again, much higher than that Pericles registry. 28 patients, you can see here that they had 17 with high flow or early sac filling. These were all treated. They weren't happy with leaving the OR with these, and you can see the different modalities used here. The low flow they chose not to treat intraoperatively. So what other treatment options? You can repeat angioplasty and extend the cuff or chimney proximally. You can do endostapling. You can do open conversion, and you can try to be creative and plicate that neck. Embolization is also an option. This is the repeat angioplasty, just going back in with balloons and trying to mold that seal zone. You can extend a cuff, and you can see here that this is the culprit area where you can have that leak. Endo anchors, the Aptus device has been used. This is also Michel Reinen's, a case series of 2 patients published this year, where you can see that the endostaplers are positioned about 30 degrees away from that chimney. It can be very useful and successful. These are 4 staples that have tacked down that gutter leak. This is Murray Shames' patient here, again, a gutter leak that's been tacked down with an Aptus endostaple. Open neck plication I mentioned to you earlier. It's a little bit creative and perhaps aggressive, but you can certainly open up the patient and try to plicate that gutter leak as well. Embolization, Dr. Wu just presented a paper on treatment of type 1 endoleaks, and this is his experience, or case report from this year, using transcaval access to the sac, and there's some purported advantages which intuitively make sense, and that you're not risking disrupting the proximal seal by trying to come arterially from above. You can also use retractable coils rather than glue. They can be more precise and minimize risk of non-target embolization. You can, of course, protect through brachial access, and this is his nice, very elegant picture showing the type 1A gutter leak after coiling very selectively with the detachable coils. So these are options. Going back to that Shames experience, you can see here that no patient left the OR with a high flow endoleak, but some were converted to low flow. So that was deemed sort of a temporary success right there. You can see here that their conclusions here is that 73% of the low flow gutter leaks resolve with observation alone. But what about the ones that don't? And these are the 8 patients here that had gutter leaks at 6 months. These are, again, low flow, but they needed to be watched. Surveillance is very important. And you can see these patients, actually 5 of them required intervention for sac enlargement. So surveillance with CAT scan is very, very important. Again, a review here, 8 of these postoperative endoleaks persisted at 6 months, 5 required additional intervention due to sac enlargement, 1 rupture required open repair. There was no significant predictors for having intraoperative endoleak in multivariate analysis. They looked at various things. The only one was really the presence of an endoleak. So in conclusion, gutter-related type 1A endoleaks represent relatively frequent occurrences after snorkels or chimneys, but the natural history may be more benign than originally feared. Available studies are limited by modest sample size and midterm follow-up, limiting assessment of clinical differences between low flow and high flow gutter leaks. Low flow leaks appear to be more likely to spontaneously seal, but again, even those low flow need to be watched carefully. Again, all leaks with sac enlargement should be addressed. And the treatment of a type 1A gutter end leak consists of reballooning, cuff extensions, endostapling, and open repair, as well as embolization. I left off there. Finally, surveillance. Surveillance is important. It means critical to monitor for aneurysm sac expansion and prevention of delayed rupture. Thank you for your attention.